This is my presentation. It's on multidisciplinary approach towards revitalizing primary health care, and the abstract is on reduction of unmet FP needs through provision of voluntary surgical contraception in primary health care facility, a case study of Kuresoi South in Nakuru County. So as I said, I'm a technical officer working for Gold Star Kenya and the USAIDTujengeJamii. Gold Star is a member of the consortium under the USAIDTujengeJamii, where we have 3 partners: Deloitte, which is our prime partner, we have Gold Star Kenya, and we have FHI 360. So Gold Star is a member of that consortium, and USAIDTujengeJamii is a 5-year USAID funded project with the purpose of increasing access and demand for quality RMSH, nutrition and wash through the system strengthening. As you all know, there's those pockets of every county where we have challenges. In Nakuru County, we have Kuresoi South as one of them, where we have a big population of underserved population, which is kind of marginalized for various reasons, and they are faced by serious geographic and cultural challenges and limited number of skilled healthcare providers, making service delivery a bit of a challenge. So, as you all know, we have pillars in safe motherhood, and family planning is one of it, and FP is one of the pillars in reduction of maternal mortality in the developing countries. We know that without family planning, you get a pregnancy which mostly is wanted or unwanted, and out of that pregnancy relates to maternal mortality as one of the outcomes, which is unaccepted. So in the year 2021, the mCPR in Kenya was around 54%. Nakuru County had 71.4%, while Kuresoi sub-county was as low as 41.6%. So the project, USAIDTujengeJamii, in partnership with Nakuru County Department of Health, had this strategy of increasing the long-acting and permanent contraception to this region. And how it was done, it was mainly the transfer of expertise of the voluntary surgical contraception to from the higher level facilities where they have the theaters, they could do that surgery. We transferred that expertise to the low-level primary healthcare facilities to support these clients and address the unmet FP need. In the context of my presentation, I'm relating this strategy to the primary healthcare approach. We all know about the Alma Ata Declaration, definition of PHC. You note the keywords and see how it applies to the concept. So, by definition, it's essential healthcare based on practical, scientifically sound, and socially acceptable methods and technology which are universally accessible to individuals and families in the community by means acceptable to them through their full participation at a cost that the community can afford in the spirit of self-reliance. The community sensitization on unmet FP need, mobilization and referral for these services was supported, where we included the super mobilizers and the male champions. We know the community around there, even as Africans, patriarchal approach is the way. So by use of males, the services could be well accepted. So the skilled health provider, who are the surgeons from the main facilities who could be able to offer the service, was supported to take the services, that's the mini laparotomy, to the lower level facilities where we don't have theaters. So this procedure could be done comfortably under local anesthesia on condition optimal infection prevention control was being observed. And the clients were not charged a single cent because we facilitated the surgeon to go to the site and offer the service. As we were doing this, capacity building was being supported to the healthcare workers in those low-level facilities by working with the surgeon and the assistant surgeon so they could grab the skills and the concept, so that in case of the project exit, we have built capacity that could be used to escalate this in line with sustainability approach. So in summary, the results of this, in the last 4 quarters, the mCPR in Kuresoi improved from 37.6% in April 21 to 57.5 in March 2022. That's in the last 1 year span. This data is available in KHIS. Then the clients that were offered the BTL services increased from 0 to 12 by the end of March in the primary health facilities that were supported in the sub-county. To some point, we are finding it a bit of a challenge even in keying this data to the KHIS, because the HRIOs would say this low-level facility cannot do a surgical contraception, and you tell them it was done through this innovation, which is scientifically sound and socially acceptable in the communities that we were taking this strategy to. In conclusion, in hard to reach and underserved populations, reduction of unmet FP need and improved FP coverage can be achieved in this very high impact intervention. And again, community sensitization and appropriate referral, coupled with transfer of expertise to the primary healthcare facilities, is a high impact intervention in resolution to the primary healthcare concept. Finally, I would like to acknowledge the USAID, who is our donor, the partners we work with, that is inclusion of Nakuru County, Department of Health, and the implementing partners in the consortium of USAIDTujengeJamii. Thank you.